Thank you, Yvonne. Following these very interesting talks, let me introduce the next talk by Dr. Jorge Bezerra. It's entitled Biomarkers of Diagnosis and Disease Progression. Let me remind the audience that the questions could be posted in the Q&A pad even during the presentation. So after we finish, we'll have a few minutes to answer some of the questions and they will be ready for us. Thank you.
Thank you, Dr. Rombo. Can you see my slides?
Not yet.
Not yet, Jorge.
I will get there. And you should see it about now.
Yes.
Great. So thank you very much for the chance to talk about biomarkers of diagnosis and disease progression. Dr. Carpen made this a very nice transition when he talked about biomarkers. It is a real privilege and honor to spend this day with you and especially sharing these pieces of data in the next 30 minutes. I'm speaking to you today from Cincinnati Children's Hospital. It is sunny here, but also very cold. But the entire city is happy because the Cincinnati Bengals, that's the American football team, is gonna play on Sunday for the national championship against the Los Angeles Rams on Sunday evening. So this is for the Super Bowl. In this picture, on your left side, we have the Cincinnati Children's Hospital Clinical Tower that has 720 beds for the care of children with acute and chronic diseases, and in close proximity to the research buildings, and I'm in the Science and Translational building that is a little bit south of the clinical tower. This slide summarizes the three components of this talk. I'll be talking about how, what are the new advances on predicting diagnosis with biomarkers, what is recent advance on how we can predict attempts to how to predict outcome, and then finish with biomarkers of portal hypertension. This is the natural history of biliary atresia, already discussed this morning by two experts, Dr. Carpen, Dr. Davenport. If we do nothing, the patient will need liver transplantation. The hepatoportoenterostomy changes the natural history of the disease and sets a new one after the surgery. One uses nutritional support with supplementation also with fat-soluble vitamins, and also you already heard a touch about the controversies about do corticosteroids, antibiotics, and bile acid targets work. Despite all the efforts, many patients have progressive liver disease and the complications of cholangitis, cirrhosis, portal hypertension, and others that you are very familiar with. What we want is do our best to prevent the patient that ends up with malnutrition, large liver, cirrhosis, sitting here at the time of liver transplantation. This patient, however, actually did well after liver transplantation, but we can do better, make sure that the patients go to surgery in much better condition. Overall, how can we improve the clinical outcome of these patients? Well, there are several factors that have been studied and shown to influence the response to surgery, such as age of the patient, but also clinical form, the variable degrees of inflammation and or fibrosis at the time of Kasai, the experience of the surgeon. But perhaps I'll argue that one that is most consistently leading to similar results in studies of age at the time of Kasai. There are several papers that address that. I will show you the data back in 2013 because Jimenez Rivera et al. Really looked at the incidence or the influence of age, reviewing several reports from different countries. So I'm going to summarize them here for you. In this paper from France, the patients that were younger than 30 days had biliary drainage at about 66% at 2 years after Kasai, compared to 42.7% for those that are older than 60 days. From Canada, they looked at 40 at only 4 years of age, and you compare if they're younger, at 4 years of age, it was 49% compared to 23% if they're older than 60 days. From the United States, only having data for 5 years, again, 62.5% compared to just under 30%. And then I see from Brazil, at 5 years of age, 54% versus if older than 90 days, only 26%. So let me review a few papers on how can we do using the tools that are existing, that we can predict the diagnosis of biliary atresia so that we can execute the Kasai in the younger age possible. Today is a clinical algorithm, the diagnostic algorithm that many of us use in the clinic. In addition to history and physical examination, we often do a series of laboratory studies, biochemistry, alpha-1 antitrypsin phenotype or level. We test for rotavirus. We do metabolic screen depending on the practice, the site of practice and who you work with. You also do your analysis, ultrasound. You may do a HIDA scan, and perhaps some centers do nasal duodenal string or radiological studies. I call your attention that, like you, we all know that we give a specific value for GGT because a higher level often is associated with biliary atresia. The presence of CMV, as discussed with Dr. Davenport, not as a diagnostic exclusionary test, but whether the patient may also have CMV. Using ultrasound to look at the bile duct and whether the gallbladder is contracted, and then finally, the absence of excretion and HIDA scan. In one of the studies that came from the Children Network, the analysis was led by Dr. Ben Schneider. The group looked at several of these factors and developed an analysis to see, looking at the receiver-operated curve, which one of these factors combined or individually increase the diagnostic reliability of these factors. The model, putting all of them together, has an AUC of about 0.89. As you can see, GGT alone is 0.84. So one could argue that this is already a major representative of this overall model, as well as the abnormality in gallbladder of 0.86%. So we can actually get very close to diagnosis prior to doing a liver biopsy or the intraoperative cholangiogram, what is actually the time that one makes the diagnosis. A group led from Professor Shan Zhen from Shanghai looked at several patients and looked again at the clinical features present by history and physical examination and bilirubin, and saw that these three elements, gender, weight, and GGT, plus bilirubin, had the highest separating features towards biliary atresia, or low or non-biliary atresia, but leading more towards the neonatal cholestasis group. She followed this up and added to these clinical and biochemical features the aid of ultrasound. In this study, published last year, they looked at first, got the large database, applied univariate analysis to select first the most likely elements, and then applied a rigorous multivariate regression analysis. Please note that they use a large cohort of over 1,000 patients in the training group, and then 500 patients in the validation cohort. For biliary atresia, they added the features of the gallbladder, and you can see on the left, abnormal gallbladder, contracted almost absence, and a normal filled gallbladder on the right, and the extrahepatic bile duct being obstructed on the left and patent on the right. Putting the ultrasound and the clinical and biochemical features together, focusing on the top portion of this figure, you can see in the red color that they have a much, that improved incrementally the reliability of this nomogram to differentiate biliary atresia from non-BA patients with cholestasis. Now, in one of the previous sessions, someone talked about, can we actually use transient elastography to assess how the patient has advanced liver fibrosis? In this patient, the investigators from Taiwan actually asked the question, do measures of liver stiffness using FibroScan above 7.27 kilopascals are predictive of biliary atresia? This was a prospective follow-up study with 61 patients with cholestasis compared to 15 with biliary atresia. And they found that a level above 7.7 kilopascals has a positive predictive value of 100% if the patient is up to 90 days of age. With a negative predictive value, very good again, vary between 91 to 100%. For those that were older than 90 days, the best value would be greater than 8.8 kilopascals, with positive and negative predictive values having accuracy of about 100%. In this graph, you can see a simple 2 bars showing that the liver stiffness measurement is higher in BA. But then in this table shows that indeed, for those that are younger than 90 days, there is no overlap, and all the kilopascals for the non-biliary atresia are less than 7.7. And those that are 91 days and above really need to have a liver stiffness measurement above 8.8. This will be this number here. But as you can see, a limitation of the study is that the groups then became very small, and there's need to undergo further validation with much larger cohort. But we took a different approach, and did serum proteomics study led by PUC, Dr. Lurtudufanit, in about 175 patients with biliary atresia and 70 with intrahepatic cholestasis. I'll summarize her findings here. It was published in 2017. That identified MMP7 and another protein, ENPP7, having very high area under the curve value of 0.99 to differentiate biliary atresia from non-biliary atresia patients. As you can see in these 2 graphs, that most of the accuracy came from the single biomarker, MMP7, compared to GGT from the same patients. And then combining GGT with MMP7, you go back again to about 0.98%. I encourage you when designing studies to always have a validation cohort, because it's never, most often, it's not that tight and high numbers, as shown here, that you still have a very high AUC, but not like the discovery cohort. This study was validated by investigators in Taiwan. They showed here sensitivity and specificity for an MMP7 levels above 1.43 being very high. And compared with GGT, they will perform slightly less well. And then by a group in Shanghai, also Professor Shen Zhen, that again looked at 187 patients with biliary atresia and 101 with non-biliary atresia patients with neonatal cholestasis, with a much higher median level for 6 MMP7, with a very high area under the curve of about 0.98 compared to 0.87 for GGT in blue. I really like this study from the group in Hong Kong, and Dr. Paul Wong, Hung Tem will be one of our speakers later today. He was a co-author in this paper. And this paper did a systematic review of the published papers on all biomarkers that were published before August of 2020. 51 papers met eligibility criteria, and data from 12 papers were extracted for further analysis, totaling about 4,182 patients. And then they assessed the performance of MMP7, interleukin 33, and GGT to diagnose biliary atresia, and then actually look at predictors of portal fibrosis, specifically APRI score. So they showed here in this graph, first MMP7. As you can see that the sensitivity and specificity are very close, all to the right, pushed to the right, with a pooled sensitivity of about 0.96% and a pooled specificity of 0.91%. These are the 4 publications that they included. This compares with interleukin 33, and you can see here that there's variability on the performance based on the published studies, with a pooled sensitivity of 0.77 and a pooled specificity of 0.85. Compared also MMP7 with GGT. GGT has a pooled sensitivity of 0.8 and a sensitivity of 0.79. Studying with a group of investigators from Wuhan University, we actually used antibody-based ELISA to look at which serum concentration would be giving us higher predictive value for the diagnosis of biliary atresia. Looking at simple means, you can see here that there is a general trend that is statistically significant to be high in patients with biliary atresia compared to non-BA age-matched controls. And then we also included normal controls and then all the subjects and adults that show that 6MP is quite low in those groups. And performing an AUC of about 0.99 for MMP7 compared to 0.7 in GGT. So today, we are exploring a change in algorithm that after some simple basic tests and ultrasound, one can actually do MMP7 and then bypass liver biopsy for an intraoperative cholangiogram. Let me review with you a study that we performed in predicting the outcome. But first, let me start mentioning to you that the paper from Hong Kong, that systematic analysis, showed that the APRI score is probably the best reliable indicator to predict patients that have portal hypertension and had relative predictive value, perhaps in identifying outcomes. What I share now with you is a study that was led by Zhenhu La that looked at liver gene profiling and diagnosis in trying to see, can we predict those that have improved outcome after Kasai? Again, he used a discovery cohort with 121 liver biopsies compared to a validation of 50 liver biopsies. Used standard analysis, and he designed a mathematical way to assign a score to each patient, assigning the scores based on the collective signal intensity. He could identify a patient that had improved survival in blue and low survival in red. And he validated that, but you can see again, still significant, but there was a shift downwards. Looking at why do patients have higher 2-year survival after the Kasai procedure, he noted that a lot of the genes related to the expression of proteins that control oxidative stress, especially as it relates to glutathione pathways. So then we took one step further and injected mice with N-acetylcysteine as an antioxidant or a mitochondrial-based antioxidant, the magnesium TBAP. What we found was only giving N-acetylcysteine, we were able to decrease liver injury and improve survival in those mice that received NEC, with a decrease in total bili, as well as a decrease in liver enzymes. And note that the other antioxidant, the mitochondrial-based antioxidant, did not provide that effect. So you can see this on liver biopsy also showed a decrease in the serous red staining as an indicator for fibrosis, as well as a decreased number of bile duct profiles. In addition, the N-acetylcysteine produced lower levels of genes involved in fibrosis, such as actin A2, collagen, TIMP, and TGF-beta1. So last, how about biomarkers of portal hypertension development? How can we monitor that? And I go back to the study from Dr. Paul Wong-Hung Tam that showed that the APRI score, as it identifies fibrosis as a marker of cirrhosis in biliary atresia, they had a pooled specificity of 0.61 and a pooled specificity sensitivity here for 0.61 and specificity of 0.8. For cirrhosis, it's better than for fibrosis, where that goes from still at 0.8% and a poor specificity and a sensitivity of 0.78. Better, but still room for improvement. How about other molecules such as ApoA1, TIMP1, TGF-beta1, adiponectin, and osteopontin? These proteins have been suggested to be predictors of portal hypertension. I'll share with you another serum proteomic studies that was just published in Hepatology Communication. And in this study, we looked at patients that were classified as having portal hypertension using biochemical clinical parameters compared to those without portal hypertension. And again, we did use the same study design with a discovery cohort and a validation cohort. This is baseline characteristics of the discovery cohort. You can see that they differ by the group of patients with portal hypertension having higher AST, higher bilirubin, but especially lower platelet count. How do, from about 1,300 proteins, these 4 proteins had a very high area under the curve above 0.9, both in the discovery and the validation cohort. Others like SFRP3 alone were high on the discover, but low in the validation, and we did not pursue them alone. You can see here how they performed. 0.9 for SEMA6B, combined with SFRP3 increases 0.95, 0.94 was a SEMA6B and COMD7, and then a combination of VCAM1 and BMX at 0.9, with again, very high performance in the validation cohort. We use the same data set to look at previous biomarkers that have been suggested in the literature in patients with biliary atresia, and we found that they only had relatively lower levels of accuracy. These proteins have variable biological functions, such as potential value on liver fibrosis, Wnt signaling, and others. But let me call your attention that one of them, SEMA6B, although not very expressed in the liver, is highly expressed in the highly expressed in the liver and gallbladder, but much more so in the immune system. But when we look at the immune system, it's primarily the spleen. So perhaps a combination of high spleen producing the high expression of SEMA6B and some coming from the liver and gallbladder. We can use these to potentially design new treatments, such as the use of N-acetylcysteine that is being studied by the group in Texas Children's Hospital in Houston, using first an IV infusion of NEC for 7 days. The study results are not available to the public yet. So the take-home messages, MMP7 seems to be a biomarker of greatest predictive value for biliary atresia. Serum elastography is very promising, with high discriminative performance, with high kilopascals of 7.7 and above for the younger patients up to 90 days of age, and 8.8 greater than 91 days of age. Fibrosis gene expression in the liver diagnosis predict poor outcome, and the biomarkers, the new biomarkers of fibrosis, in addition to APRI, include SEMA6B, SFRP3, COMD7, BMX, and VCAM1. I want to thank the investigators in our laboratory and support from the NIH and from the Children Network. Thank you very much.
Thank you, Dr. Bezerra, for this very detailed and complete presentation. I think to be strict with the time, we might have a time only for 1 or 2 questions.
While we wait for the public to make their comments, maybe I can have a question for Dr. Bezerra. Congratulations on your lecture. It was very interesting. I don't know if you agree with me. In general, we are looking for markers in diagnostic sense. We are looking for markers of positive predictive value on the diagnosis of biliary atresia. But are you aware, I mean, don't you think that we can be more focused on markers of negative predictive value? Because with that, we can avoid to going into more aggressive methods like cholangiography and so on. What do you think about it?
I think it's very important, and you can actually use the existing markers from GGT and MMP7. It depends on what you want. You can lower or increase the value of the biomarker so that you can achieve the endpoint that you want. But you're very right. Knowing which patients not to take to the intraoperative cholangiogram is very important.
You made a comment about FibroScan on their negative predictive value. Do you utilize this in your service?
So we don't, but several practices in the US are beginning to use that. I think that lower values of FibroScan actually have a high predictive value of not being biliary atresia. So I think that we want to see studies that look at that with a larger patient population so that we have a better understanding of the the kilopascal measurement that we can use as a cutoff point, if you will.
Okay, there are some questions. Dr.
Yeah,
Bezerra, Dr. Argemi asked you about if it's possible any mechanism insights from both MMP7 or SMAA6B. Do you think they are having a causative role or are just innocent bystanders?
I can only share some insight into on MMP7 that as a pro-inflammatory matrix metalloprotease, it actually increases, has a property to increase the infiltration of myeloid cells to the tissue. And using experimental models inhibiting MMP7 decrease the number of mice that developed biliary atresia experimentally.
Thank you. I think, Carolina, we are running out of time. I don't know if there is some more questions.
I agree. I think we are on time just to move on for the next part of the session.
Thank you, Dr. Bezerra. Nice lecture, and let's go on.